So again, bienvenue tout le monde. Welcome everyone to this session for the presentation of the new update National Clinical Practice Guideline for the Management of Opioid Use Disorder. As many of you have seen, I guess, this guideline was published this Tuesday in CMAJ. I have the pleasure to co-lead the guideline with Igor Yakovenko, who is the scientific lead and the clinical lead. I'm Julie Bruno, I'm from the University of Montreal, and I'll leave Igor present himself. So what we intend to do this afternoon is go through the presentation of the guideline, explain to you the rationale, the methods, the recommendations, what it means, and we'll do this for about 40 minutes and then having a discussion with you, hopefully will be very lively. And then I will present the other question that we had when we did a lot of consultations on and basically it is, what can we do to bring some recommendation and guidance into the safer supply field. So that will be the second part of the presentation, and then we'll have a discussion afterwards for that second part. So without further ado, I'll just introduce my colleague and partner in crime for this management of opioid disorder, Igor.
Thank you very much. It's a pleasure to be here to speak to you about this. As a brief introduction for probably most of you who don't know me, my name is Igor Yakovenko. I'm an associate professor of psychology and psychiatry at Dalhousie University in Nova Scotia, where I broadly focus on addictive behaviors. I'm a psychologist by training, so you get a little bit of a different perspective perhaps. But working with many physicians, I think we tried to marry all kinds of different models to come up with the updated guidelines. So I was the scientific lead for this, and my job today is to help you understand what the new recommendations are, how did we arrive at them, and some considerations. Just figure out how to work this. There we go. Some disclosures for both Dr. Bruno and me. For those who haven't seen it, the guideline actually has been published in CMAJ as a synopsis, and there's a QR code there. If you haven't taken a look, you could just pop into it right now, and there's a link to the full 186-page guideline from the synopsis as well. So if you're interested in all the details, that's there. You can read all about it. It's been out for a couple days, and I think pretty accessible now. I'll give everyone a moment. I see phones going up for the QR code. So today I'll begin with some rationale for the update, why we did this, what went into it and why now, then review for you the actual recommendations and talk a little bit about the implications and what we should take away from this. As a background, I think everybody in the room will probably already be aware of this, but the original guidelines published in 2018 were really a response to the rising opioid crisis, and at the time we didn't really have a national guideline to try to recommend some sort of standard of care. So if you haven't seen this before, in 2018 there was an original guideline published by Crism, the Canadian Research Initiative, at the time in substance misuse, now substance matters, and it represented the first iteration of what I'm describing today. So we didn't start from scratch. It was an update to those existing recommendations, which shaped some of it. If you're not familiar with Crism, who's behind all of this, Crism is a national network of clinicians, researchers, persons with living experience, administrators, all across Canada, funded by Health Canada and CIHR. The goal is really to try to develop and produce science and clinical interventions for substance use and addictive behaviors broadly, and it operates across 5 nodes. And so, for example, Dr. Bruneau is presenting with me today. She's the nominated principal investigator for the Quebec node, and we have others at the conference here, like Dr. David Hodgins, representing the Prairies. So if you haven't engaged with Crism, I highly recommend that you chat with them, or those of us part of Crism, because it's a great network to be a part of. So why did we do this update? Why now? And it came down to a couple big reasons. One is that it's a rapidly evolving field. As you'll see, just in the 6 years alone that we have reviewed recently for the update, there were 150 studies published on the topic that were included, and tens of thousands that were potentially eligible. So you can't ignore that kind of a pace of update. New things come out, especially with COVID. We really had to take those considerations in and provide an update. And 2, the original guideline was published as a pretty rapid response to the crisis that was happening. This time around, we had much more of an explicit goal in mind from the ground up to make it an updatable thing in the future. So the goal was to build something, the method of it, the transparency, such that somebody could come back in 2 years and do it easier and keep more and more frequent iterations in a sort of a living guideline approach. So there was a methodological purpose to help build future practices, not just create a content update. The original guidelines focused on a few specific things and excluded some others, given that this is a broad area. And we kept that scope mostly. We've changed some things, and I'll talk about some of the reasons why in a little bit. But this particular guideline focused on oral opioid agonist therapies, OAT. For example, extended release formulations or injectables were not a part of what was reviewed. Some of that was because they have their own publications, documentations, like the injectables have a Crism guideline that was published, and others are simply topics that are big enough that they warrant a separate review and aggregate of evidence and can't just be lumped in. But we will try to attend to some of that today, some of these important topics. The idea was to provide a gathering of the literature for populations with opioid use disorder, adults specifically, and then add some special considerations, pregnant people and then people who use oral naltrexone as well. The audience, of course, were clinicians and other healthcare providers with or without addiction medicine experience to guide all of Canada. Part of the development rationale was, of course, the methodological piece. We really wanted to set a standard to make sure that we do this as stringently as possible and as transparently as possible. And so the focus on this led to us really adopting all of the gold standard elements that you might see in an international kind of recognized publication, including pre-registration, following even external evaluation appraisals. It wasn't just qualitative feedback, it actually followed the particular methodology for the appraisal of the guideline when we solicited that feedback. And of course the team consisted of a number of different individuals. It wasn't just us here. The review itself followed mostly the typical procedures of searching, selecting studies, and synthesizing. But I think what's worth highlighting is that it isn't just a summary of, well, here's what the studies say. There is a separation between quality of evidence that's available and how strongly we're recommending something, and those can be different. So for example, you can have a strong recommendation for something that doesn't have good quality of evidence, right? So that separation is meaningful because you can now speak about how reliable a finding is, not just how high the quality evidence is. And it's worth highlighting that external revision process. So the work that went into this was not just researchers and scientists. There was a huge revision and review process that incorporated clinicians, researchers, people with lived experience, indigenous communities, communities of practice. So what you're seeing here is the culmination of input from all those stakeholders, not just a few people who sat down in a room and screened some abstracts. And I think that's important to highlight. It's our best version of that. one of the things that we were really mindful of is to make sure that the spirit of this update tries to recognize and adhere to what we would consider international standards of care. A patient-centered approach that takes into account preferences, goals, experience, recognition that something like OAT is just part of a continuum of care where you have harm reduction services, psychosocial treatments, and other elements that support a person's recovery, as well as consideration for things like culturally safe practices and trauma-informed care. The best way to really state this is that we screen tens of thousands of abstracts, but that's not why we do this. The idea is that we provide these guidelines for patients and practitioners to be able to do better. And it always comes back to these principles, because when you're sitting down in the room with somebody, it's about this, not necessarily all the nitty-gritty of studies. So the hope is that at the end of this talk, at the end of this hour and a half, those of you here and perhaps after reading the guideline more are better equipped to work with individuals or adults with opioid use disorder. So how did we actually do this? What occurred this time around, and how is it different? We retained a lot of the original guidelines' purpose and scope. And in the original guideline, there were 11 clinical questions corresponding to various medications and such that guided what is it that the literature review searched for. And we kind of did a similar thing where we focused on adults who with opioid use disorder of any severity, and there was this broad question of what is the latest scientific evidence for the clinical management of opioid use disorder in this population. We did add a sort of a 12th question because we specifically wanted to systematically review management of opioid use disorder in pregnant people. That was a discussion in the original guideline, but that literature was not collated in the same systematic way as we did this time around. So we were able to speak a bit more to that, and I'll mention that a little bit later. Because of the scope of everything you have to search for something like this, because you have not just the medications and pharmacotherapies, you also have the psychosocial elements, the harm reduction. We separated it into two big searches, and one was the pharmacotherapies, and the other one was the psychotherapy interventions and harm reduction. And this literature captured here is up until about a year ago, just over a year ago. It's the fastest we could do it to get it out there, given the scope of things. There were some exclusion criteria, and I think one of the important things to highlight here is that the types of studies were expanded. In the original guideline, the focus was strictly on controlled trials and meta-analyses and aggregate data. Here we actually included observational studies as well. The goal was to capture whatever was available quantitatively. We did exclude case studies and qualitative information because it makes it difficult to use that data for generalizing, but we did not want to exclude every single study that wasn't randomized, for example, because there are a lot of those, and if they show a pattern of results, then they're meaningful and could be used to support some kind of conclusion, or at least as a supplement. So that's one change, but I think the main message from here is that we excluded certain kinds of interventions like injectables, extended release agonists and antagonists, and then essentially non-peer reviewed, non-quantitative literature. This slide looks busy and it just looks like Excel boxes, but what it's important to highlight about this is that we followed the typical systematic review procedures that you would see nowadays using software like Covidence, but there was a goal here, and the goal was of transparency and accessibility. So for example, the creation of these data synthesis tables and data extraction, from the beginning we wanted to make sure that whatever we create, somebody can use other than us and actually look at this stuff. And so now, if you're interested, and you click on the guideline and follow that QR code, you can see every single thing that was extracted in a nice, neat way. You can see every study, every outcome, what was included, what was excluded, and it's all organized and collated. So it's not a mystery. It's not something you have to go digging for. It's just there. And so I think that's another nice benefit, is that I think we started something here that could be easily then worked with by anyone, not just our crew that did this on the team. The other important piece to highlight here is that because we had different searches and different kinds of treatments and interventions for opioid use disorder, we had to think about what kinds of outcomes are important to capture and study, because they're not the same, they're not equivalent. So we had 6 main outcomes for pharmacotherapies, but as you can see on the bottom there, when we looked at the psychosocial interventions, we added some others. Mental health is an example, and we took out adverse effects because that doesn't necessarily apply in the same way to psychosocial interventions. And similarly for harm reduction, there were other considerations such as HCV, HIV incidence prevalence, because that's what often is the focus when you're working within that system, when you're working with harm reduction settings. For each one of these, we had 2 priority outcomes that we emphasized somewhat above others when we were looking at the literature, and specifically for the pharmacotherapies, it was treatment retention opioid use. We really wanted to say that what matters the most out of all the outcomes is using and reducing that and staying in treatment, which was again gathered based on consultation. It wasn't just a random choice. And then for harm reduction, that was shifted to non-fatal overdose and mortality, because that's often what we care about the most when we're trying to look at the effectiveness of a harm reduction approach. Each study that was collated, we tried to, again, follow the best available standards methodologically for assessing bias. So it's not the case that we simply looked at these and treated them all equally. There was an actual quantitative approach to being able to say, this is a bias study, this is a less biased study, and evaluate it that way. So we do, again, that information is all available to give you a sense of the quality of the data that was published over the last 6 years. And it was matched up to the type of design for each study. So again, these are busy slides, but for those interested, I think these kinds of Prisma diagrams are most useful for seeing the scope of what was produced, right? And so if you look at something like this, you can see that over 6 years, almost 15,000 studies were published that were maybe potentially relevant. And somebody has to sift through them and figure out if it matters. And in the end, 105 were included as actually meeting all of our inclusion criteria. So lots of work on this. And same for the psychosocial harm reduction search. You see a little bit more studies published in terms of relevant abstracts, but in the end, much fewer included as being relevant. And that makes sense because the focus is in OED very often on pharmacotherapies. So all in all, about 150 studies that are new and a part of this update that were collated and informed the updated recommendations. And I think you know, just the sheer number and volume of these abstracts give you a sense of what was screened and the team involved in trying to do this. So this is definitely not a solo effort. I mean, I think it was over 1,200 full texts that were read and sifted through in the end. You know, so ask yourself when the last time was that you read 1,200 studies for one study publication. I mean, that's sort of the scope of the work involved. So that was a brief overview of the methods, how we extracted the data, but what is the meat of this is of course the change itself. What did we produce here? One thing to note before I talk about each new recommendation is that you'll see the presentation of the recommendations separated based on how they were, the evidence was assessed versus the strength of the recommendation itself. So we use the grade approach, for those familiar with this, to assess the risk of bias and the quality of the evidence for each recommendation. So the best way to think about that is when you look at certainty of evidence, high, moderate, low, very low, it's really a statement about how good of a quality of studies are out there for this. You know, is it something we can rely on? Is it something that we can believe strongly and have conviction in, or do we need a lot more work on this to have confidence? And then the strength of the recommendation really reflects more how it should be used in the real world. So if something is a strong recommendation, that doesn't mean that it's really good quality evidence behind it. It really reflects the idea that if it's strong, then most patients would want to recommend this to others they know, and then practitioners and clinicians would be comfortable recommending this course of action, again, to most people. And if it's not strong, if it's weak, then it's the opposite, that there's a hesitation there around this recommendation. So think about these two elements as you're seeing this information, because I think it'll give you a better sense of more like a practical application versus the scientific part of it. So the first big change, I think, is that in the original guideline, the first line treatment was buprenorphine, and methadone was not considered to be equivalent, or was not recommended to be equivalent. Since then, over the 6 years, we had a number of studies informing these medications. They're the most common type of design and focus in this research. And what's changed is that we're now recommending that buprenorphine and methadone become equivalent in first-line treatment. And that has to do with some of the substantial new evidence that's been generated. You can look at the list, of course, for different types of outcomes, but you see multiple meta-analyses, multiple randomized controlled trials, multiple cohort studies, dozens of cohort studies. And one of the, I think, messages here is that this topic's actually been studied quite a bit, the methadone buprenorphine comparisons. And what you see time and time again emerging, and it's not just our work highlighting this, some of the posters even highlight this in the room today, is that the difference is really in small parts of the different outcomes. So for example, methadone, there we go. Methadone has mortality risks, so there's an increased risk of mortality in the first month, and buprenorphine has increased risk of retention or dropout in that first month. And so you see something like that, it's hard to say, well, one is better than the other, because it really depends, again, on the setting you work in, the priority, the patient you're working with. So that's where this idea that they're equivalent comes from, is that you don't see clear differences between them across the trials and meta-analyses. You really see these more minor differences depending on the outcome. And so in truth, they're equivalent depending on your context. And so that's our recommendation. And this is something that, again, there's high confidence in, high certainty of evidence. I think perhaps another message here is that this has been studied quite a bit, and maybe other parts of the guideline and some of the other medications need more focus and more research. And speaking of, slow-release oral morphine in the original 2018 guideline was something that was discussed but not firmly stated as a second-line treatment option, because at the time you need a Section 56 exemption, that's no longer required. But over the last 6 years, I think the big piece of the message here is that SROM is not getting much new work done. We're really getting limited number of studies here. You see 2 meta-analyses, 5 cohort studies, no randomized control trials that were conducted. So it's hard to make a change in the recommendation, except to say that we're not really getting a lot of quality stuff produced in the last several years on this. So we can say that it can't be equivalent to methadone buprenorphine in terms of a first-line recommendation, because just the evidence isn't there. So there's some evidence, and that certainty is moderate, so it's not low, but we have a strong recommendation to reserve slow-release oral morphine as a second-line option following methadone buprenorphine. And so I think our personal message is, if you're doing work on this, please do more studies on slow-release oral morphine, because compared to the other medications, it seriously lacks new literature and investigation. The next few guidelines, or recommendations, I should say, they haven't changed very much from the original, because either new evidence produced didn't dispute it, or there just isn't very much of it. So for example, for withdrawal management, the original 2018 recommendation was essentially a very cautious approach, and to avoid it as a standalone way of managing opioid use disorder, and we're sticking by that. So in this regard, that stands. You really see very limited new evidence, and in those scenarios where we had very little new evidence, we carried over from the previous guideline because we really don't have grounds to change things without new evidence. So very little work on this again, and not a lot of confidence in us being able to change this. Similarly with the slow taper approach, the idea of changing the taper protocol is very rarely investigated. You can see one RCT produced, and again, with such limited new evidence, I mean, you can see here we're even saying very limited. It's not just limited because just almost no work on this. It's hard to do anything but carry it over, so really no change from the previous recommendation on this. The recommendation is that withdrawal management alone is not sufficient to be able to match the effectiveness of opioid agonist therapies. This reflects the same kind of story, different aspects of withdrawal management, where there's discontinuation or slow tapering, you see the same picture emerge. Very little work, no randomized controlled trials, so we can't really recommend any kind of new changes. I think the consideration here is this: for those who wish to discontinue OAT, you really need to make sure that there's ongoing care, monitoring, and a slow taper approach could be considered, but it's all in context depending on the patient. One of the larger changes, I think, accompanying this particular update was the psychosocial and harm reduction treatments. In the original guideline, there was consideration, and they did capture psychosocial treatment, so therapy essentially. And at the time, the recommendation was to recognize its benefit and to routinely suggest it. So the framing was one of, this is a useful thing. You should suggest it to patients, and it could be helpful to everyone. Over the last 6 years, we really don't have good evidence to support the idea that psychosocial treatments improve incrementally above OAT alone. And so one of the changes that we made is actually separate that recommendation into two pieces. The first piece was to highlight that psychosocial treatments are helpful, and they can help with retention, for example. So if you're working in that kind of context and you want to see benefits in those domains, or for others that psychosocial treatment targets, like comorbid mental health and such, absolutely. But if we're focusing on opioid use, then you see, and you can see this across the studies, you don't really have much evidence across a pretty large number of trials and meta-analyses in the last few years, comparing OAT alone to OAT plus therapy. The effects are pretty much equivalent for those main outcomes of opioid use. And so what we did there is then introduce a second recommendation in this domain, which is that psychosocial treatments should not be a mandatory component of standard treatment for OUD, and importantly, shouldn't prevent access. I think the big message with this particular change is that we don't have strong scientific evidence to suggest that a patient who wants to go on OAT and would like to engage with that must engage with therapy in order to succeed there, see the benefit. So therapy and psychosocial engagement should not be a barrier or a requirement to get OAT, because the evidence just doesn't support that. If there are other reasons for suggesting it, that's perfectly fine, but as a requirement or precursor to access to OAT, that's a change that we're recommending. Moving on to harm reduction, this one is in 2018, again, was relatively unchanged, because at the time there was a strong recommendation with some moderate quality of evidence to support a variety of harm reduction programs, such as sterile injection supplies, safe consumption sites, and it was suggested to be part of standard care with the evidence we had. In the more recent years, we see some new evidence provided here, but not a ton. And the revision here is minor, but perhaps important to highlight, because in the original guideline, harm reduction services that were listed, so the specific harm reduction services, they were really used as examples of harm reduction. So it wasn't the case that the evidence was mapped on to what exactly was studied. So when a list was stated in the original guidelines as an example, and it said safe consumption or needle exchange, it wasn't that there were this many studies for needle exchange and this many studies for safe consumption. Well, this case, we actually looked at what was studied, what kind of harm reduction services, and specifically tried to map the wording of the recommendation to that. So you could see how when something is listed, such as provision of sterile consumption equipment, overdose prevention. It's not because we don't care about the other kinds of harm reduction services, because that's what was studied. This is what we have the evidence for in the last 6 years, and the other harm reduction components were not. It doesn't mean they're not effective, because there's a vast new literature there preceding this update, but it's more about specificity and clarity of language, so that there's a consideration for exactly what kind of harm reduction service you're providing, not just any harm reduction. Oral naltrexone, this was something that was recommended as an adjunct medication if you achieve cessation of opioid use back in the 2018 guideline. And this was really the weakest of the recommendations at the time, because you could see how the quality of evidence and the strength were low and weak, which essentially means that there's so little data on this that even at that time they couldn't provide any kind of recommendation with conviction. And that really hasn't changed much, except move in the direction of not having any kind of potential benefit. So there's new evidence suggesting no apparent benefit of oral naltrexone, higher risk of treatment discontinuation. So the news is not good for using oral naltrexone as a kind of a sole treatment or management of opioid use disorder. So here we're no longer even stating it as a recommendation, and so one of the changes that is now a special consideration. And the best way to think about special consideration, and you'll see me use this word again, is it's a topic that needs more investigation, needs more study, and we don't have the strength of evidence to say we're recommending this. And so on that note, we also had a special consideration for pregnant people. If you recall, at the beginning of this talk, I stated that we systematically reviewed this literature. So it wasn't just a browsing of this topic. We collated all the studies done on this during the period that was captured. But because we only captured the 6 years for the update and not everything else preceding that, we can't say we're recommending something here, because in truth is we haven't looked at all the literature existing before 2018 publication of the previous guidelines. So here the special consideration is that pregnant people with opioid use disorder who are not in treatment should be encouraged to start a first-line treatment as soon as possible, because there's some evidence that you see similar kinds of benefits for them as and similar adverse effect profiles as with individuals who are not pregnant. So again, not a recommendation, but moving in the direction of strength of evidence. So hopefully next time around, the next update, it can become one of the recommendations. I think this is an important topic, because when you look at opioid use, of course, special populations are important, forensic settings, pregnancy, all of these matter, and it's not like we didn't recognize that. It's just that the literature that exists behind them is very minimal. So we're reserving any kind of strong recommendation on those topics. I think the other important element to highlight at the end of all this, so that was kind of the bulk of the recommendations conclude in some of the major changes, but before moving on, it's worth noting the review process that this thing underwent. So once we formed these recommendations, which were again by a number of individuals and committees, we then sent it out for a national external review. And this slide just highlights some confidence in what we did. So for those skeptics in the room who are maybe disagreeing with some of this, our hope is that this communicates that we consulted with a variety of different stakeholders, physicians representing the primary population, but a variety of different kinds of practitioners, pharmacists, nurses, social workers, psychologists. Apparently I'm the least represented profession in this guideline, and also people with lived and living experience. And if you're not familiar with the GRI-REC, so this is the appraisal of guidelines, research and evaluation, recommendation excellence instrument. It's a mouthful, but it really just means it's a questionnaire that's developed in a standardized way to help somebody evaluate guidelines. It's not just saying, what do you think? It actually has metrics and ratings, and we ask them to rate all of those areas like clarity, relevant, appropriateness of the recommendations in the field based on their opinion. And the key message is that pretty much everything was rated above a 6 out of 7. So pretty much everyone we consulted with felt that this was produced in a way that's clear, that's relevant, that's appropriate, and reflects the values of that target audience of clinicians. So it gave us some sense of confidence that we did something right with this. Of course, this particular work is not without its limitations, and these are important to highlight. One of the main ones is that, if you recall, we had 6 main outcomes that we chose, and these were chosen from several sources: a Delphi study, and then consultation with clinical experts to evaluate what's most relevant in the field for those working on the ground. And patient preference and cost were 2 of them. But you notice I didn't really talk much about those, and that's because almost no one is doing work on patient preference and cost as outcomes. It's opioid cessation reduction, treatment retention, the big candidates. So I think there's a clear path forward here is more studies focusing on those elements, because we really don't have a good sense of cost effectiveness, indirect, direct costs, or the impact of these different practices on patient preferences. The other limitation is, again, special population. I highlighted that a little bit, but part of it is also the limited amount of evidence. So yes, we don't quite have enough to provide recommendation, but some of these topics are barely studied. So for example, pregnancy is a more popular one, but others are really not something that very much attention is paid to at all, like the oral naltrexone piece. So I think again, more work of high quality studies on these special populations is probably a good pathway forward, perhaps away from some of our traditional methadone versus buprenorphine in adult populations. The last one is type of opioid. I'm sure some of you, and many of you in the room, are thinking, what about fentanyl and a consideration of that? Of course, we thought about that and considered it, but in truth, for almost all the studies we reviewed, very few even specified what kind of opioid the target sample used. So if you read the studies, it's almost impossible to extract who it is that they studied. Was it heroin users? Was it fentanyl problems? And so you can't systematically collate that and extract just the piece around fentanyl from what currently exists. So hopefully in the future we can, but that's why there's this palpable absence of a statement about fentanyl or a consideration, because it's just not clear enough in the methods of the published work. The other limitation piece is actually the exclusions. I mentioned them briefly, but I think the best way to think about them is separate them into 2 parts. One is the medications that were excluded from the scope of this work. I mentioned those already. They all have their differences, right? So injectables were not included, and that's because that was the case in the original guideline, but also because there was separate work on injectables by Crism and separate guidelines. And then the extended release agonists, so if you're thinking like Sublocade or Vivitrol, these are growing formulations, but it's either not available in Canada or it's the literature just isn't quite there to be able to provide any kind of judgment or recommendation. So I think maybe in the coming years, but it wasn't sufficient enough to be able to systematically aggregate and recommend something on it. The other component of topics and scope, one of the things we did before starting the work on this is actually consult with a whole bunch of stakeholders through focus groups, and you can read about that in the full guideline document, and questions about what's important to you. What do you want to see represented in this guideline? And of course, there were topics that were very important. Top of the list was safer supply. You're going to hear about that from Dr. Bruneau in just a minute here. But there were others like induction protocols, take-home doses, dosing schedules. Absolutely, they're all very important. But again, the reason they're not in this comes down to two main things. One is they're either big enough to warrant their own work, like safer supply is one of them. It can't just be a sort of an addendum little section in our guideline and that represents the totality of the discussion on this. Or there's more limited work on that. So for example, the idea of dosing schedules and such, and take-home doses. There are few studies that are actually systematically comparing them. So many describe what kind of doses they included in their protocols, but you don't see, for example, many trials comparing different regimens to be able to look at the impact of this on the outcomes. And so some of this is a limitation scientifically that is just not being produced, and others it's our own reservation around engaging in a topic that warrants its own investigation. And of course, a lot of it was also shaped by the fact that it was an update, so we couldn't just throw everything out from the previous guideline. We wanted to build on it. I think the best way to think about this whole update is it's a start of something hopefully greater. We've changed and updated the methodology, made it open, transparent, so that it can be viewed, replicated, improved upon, and perhaps some of these topics can now be followed up on with more rapid reviews, shorter reviews on a more frequent schedule rather than, let's say, 6 or 7 years apart. And so it's a foundation rather than the end-all be-all statement. It's a general practice guideline, and we certainly appreciate that all of these other topics are important when you're practicing that need to be investigated. So in conclusion, I think again, busy slide. This is more of a decision tree that you can see in the guideline and some of the infographics in the articles that represent the culmination of these changes. So how can you work with a patient now to provide a recommendation? The hope is that every single person that has opioid use disorder, has been diagnosed with that, when they walk into a medical facility, this update and this work builds the knowledge and information to take care of them. So it's a reminder to come back to this at the end of the day rather than focus on all of the nitty-gritty studies, because this is actually what matters and this is what you're dealing with day to day. I do want to bring it back to just the two articles. Again, if you're curious to follow up on this, please do take a look. We're around for the conference if you'd like to chat more details. There's a lot more information in the full guideline about all of these different processes. It's a tremendous amount of work, so it's worth highlighting just how much coordination work went into this. There's a scientific team that we're a part of, clinical leads representing different provinces and nodes of Crism that were all providing input, consulting on this, a steering committee of the researchers and principal investigators of each node, and then of course a huge coordinating team as a national effort. So thank you very much. I'll pause there. We'll take maybe about 20 minutes now or so for questions and discussion if you have it, and then we'll move on to the next connected topic of safer supply. Thank you.
Yes, thank you. Thank you. And I really want, for the question period, I'll ask Yvette and Katusha to come in. Yvette and Katusha did that thing of reading all these papers, coordinating the students who read the paper. So maybe if you have some questions very specific, they will be better than Inigo and myself to answer the question. Are there some microphone in the... room? No? Okay, so any questions, clarification? David, hi David.
Hi Julie, nice to see you and thanks for a very good presentation.
Yes.
I'm wondering when supervised injectable opiate agonist treatment will be in the national guidelines, given that it's supported by multiple randomized clinical trials and standard care in other countries.
Okay, so which one you said, the supervised?
Injectable treatment with hydromorphone or diamorphine.
The supervised injectable is actually another guideline. That's why we didn't update the two guidelines at the same time. There is one guideline and one operational. To talk about more the safer supply, which is maybe an extension in a way of you wait 15 minutes and I talk about it.
I'm concerned that politically excluding a treatment that's supported by multiple well-designed randomized clinical trials from this guideline suggests that it ought not to be a standard part of the treatment system.
I get that.
I would encourage you in future recommendations to include that in these guidelines.
Thank you. And I'll address this afterwards. Thank you.
I think there's a hand there.
Go ahead, because it's your.
Yeah.
Thank you. Thanks for Valerie. I have two questions. The first has to do with your slide on OAT and pregnancy. It appears to imply that buprenorphine is equivalent to methadone. What happened to the concept or the notion that BMT initiation requires withdrawal, and withdrawal in the first trimester of pregnancy increases your risk of fetal loss?
Yeah, so I think, and Julie can speak more to this, and Iveta Katusha, I think the slide, so this is where we have to be careful. The idea that it implies something is, this is why we didn't produce it as a recommendation. Because we're not actually trying to imply anything, as we don't have all of the considerations in place. So neonatal outcomes, for example, and some of the things you're highlighting that need to be a part of this, were very difficult to try to collate systematically because of lack of clarity in reporting. And at the same time, the limited scope of what we looked at excluded a whole bunch of the literature and the work on this prior to this. And so I think if you're reading it as a special consideration, it really is to be taken as that. It's a starting point for discussion rather than a suggestion that something should be done. I mean, I think when we say recommendation, we say, we think you should seriously consider doing this. When we say special consideration, it really just a statement of, here are the studies that were done. I don't think we're suggesting anything. And so if there's a implicit kind of message in some of the outcomes that were produced, I think it's important to recognize that it's not the totality of that evidence, and it certainly misses some of these details that are worth considering that I think should be picked up perhaps in the next iteration of the guideline and looked at more closely and considered, or perhaps even as a standalone. I know there are standalone guidelines published in the States and such for, or systematic reviews on this particular topic. So I guess it's my way of saying that we're not suggesting any of those things because of those issues and limitations.
And maybe I will add to this that we, to do a real recommendation, we would have to go back and do and so what we did in this special recommendation, but a special consideration, but also reference to the latest guidelines that were published within the guidelines. So we're stuck a little bit on this one.
And then my second question has to do with, is there no evidence for dual therapy of methadone and slow-release oral morphine? Because that was not addressed in the Crism guidelines at all.
Exactly. There is nothing there. That's why it's not addressed. And we make a strong, in the synopsis, this is one of our conclusions that's saying that it doesn't make any sense that we don't have enough studies on slow release oral morphine. That's true. Sure. And maybe on that topic, I would invite you, if you want to speak to Yvette and Katusha after in the break, because they will give you the nitty-gritty reasons why we kind of were very cautious about this thing, because there's a lot of other considerations.
Maybe I'll add, this seems to be a topic of discussion that multiple people are interested in. I think a benefit that you might extract from this guideline, even though it doesn't provide recommendations on this, is that at least the studies that were published during this period that was captured have all been systematically collated. So I think that was the intention, is that if you want to look at the totality of this literature, it's just there, appended with everything else, and you can neatly sort by studies on pregnant people and take a look at it. So the hope is that it launches and continues that conversation, moving toward a recommendation in a more clear and open way and concise way. Any other questions? So I don't see any other questions, so maybe what we'll do is we'll move on to the second part of this presentation by Dr. Pernod, who will take us into that topic I said deserves its own consideration, which is safer supply. Thank you.
Okay, thank you. And maybe we can continue this conversation about the guideline when you'll see the second part. So the second part is a scoping review and concept analysis to inform the safer supply research agenda. And I'll try to drive you to our nerdy approach to this, but also thinking about that guideline and knowing that it's an important part of it. When we surveyed, Igor told about the survey and the consultations we did with the focus group, etc. We had more than 40% of people, like clinicians, people with living experience, who really the first topic they wanted us to cover was safer supply. And we understood that, and we know that it's a, and I think as David alluded, there is other things than just the standard oral opioid treatment in Canada. So the question we had obviously was that just to put this in the perspective, alternative to unregulated drug supply is something that we know that despite the effective treatment and in front of the opioid crisis, people that are not retained in treatment and the treatment that we have are not optimal for 100% of the population. Safer supply emerged as a risk mitigation strategies, and over time, these kind of approach covered a wide range of intervention that was all under the umbrella of the safer supply. As you know, there was the CAPUD, there was the Health Canada, there was other. But if we want to, and I see nothing in my slides, but if you really want to move the field forward and generate the evidence that will put this approach in a way that it won't be just polarized and advocate, but it would also be able to grow and build an evidence, we have to do something. So we thought of it a long time, thought of it a lot. And what we were saying is, instead of trying to just grab the evidence, and you see that we've done it as well, we needed to systematically assess what was there. We needed to clarify the boundaries of what we were talking about when we were talking about safer supplies models. And we focused, even though we didn't just do that, we focused on the medicalized safer supply within the continuum of care for opioid use disorder in that particular presentation that I'm talking about. So the objectives was to summarize the literature and on safer supply, to gather the current definitions, the current classifications of what it was, to summarize the clinical use of safer supply and associated treatment, harm reduction, intervention components, what it was in it, and also to map the type of thing. And why we did this and how we did this, and bear with me here. So we did a combined approach of scoping review, of looking at everything was there, and used the concept analysis methodology of Walker and Avant, and we combined those two methods. And what it does is that we do a large scoping reviews of looking at everything that has been published on safer supply between 2010 and 2023. And then we look at the components within and trying to do what was the attributes of the program and what they were for, to build kind of a case model. What is the main thing that we see, and what is the related case, and what was in there? So to decompose, in a way, the safer supply, and then to map the literature to know what was in there. And why we did this is because if we want to move the research agenda, come from consensus of priorities and things to test and things to look at, then we need to have some kind of ideas. So what was included, I said it already, it's the studies that were assessing the feasibility, the acceptability, the availability, and the effectiveness of safer supply. And what is excluded is what you see here. And we looked at that, but in the context of these guidelines and recommendations and moving forward, this is what we retain. So you've seen this for the first guideline. It is a scoping review. It is larger, the type of studies. We reviewed overall 73 studied after having assessed more than 6,000. Interestingly, and this is important, 96% of the studies were from Canada, and over 90% were after 2021. And the literature source was about 75% from the literature and the rest from the gray literature. This, I don't want you to read this, it's fine. I just want you to look at what we've done. And we ended up having like 5 categories of models from the IOAT that was extended to the Buyers Club, or call the non-prescribed opioid buying. And then the attributes on the side are the type of services. And just from the slide, what you're seeing is that there were more services in the more medicalized, including standardized OAT plus safer supply or combination of short-acting medication than when we move to the left, I guess. This is the conceptual analysis. So we use those things and we kind of draw what was the model case. And in all these papers, the model case was actually OAT, whether it's methadone, buprenorphine, plus or minus naloxone, or slow-release oral morphine, with a short-acting opioid, and also OAT with fentanyl patch. Then what we call the related or the borderline case is when another slow release or fentanyl patch was used, but without one of the 3 medications that are in most guidelines, in our guideline and others. And then you have the related case, which is more the model that is more harm reduction, public health, non-prescribed, non-medicalized, safer supply. When we map the literature, what we've seen is about half of the programs were what I just described, and for 30-something% of the programs, they weren't very described in the papers. We couldn't extract components of their program. And then you have those other programs that are relatively marginal. Essentially, the literature, as you see here, is more either observational qualitative studies or a mixture of these. There was no randomized control trial of quasi-experimental studies. And when we looked at the outcome that were assessed, and I think it's important, what we see is, it's most of them are perception. You have some ecological studies on overdose mortality. You have a lot of qualitative studies that are looking at engagement and all these important outcomes. I'm not saying it's not important. Diversion, only 2 studies of all the studies was looking at diversions, and adverse events, only 1. So what do we do with all this? I think it's just a kind of a pragmatic, factual portrait of how we can build our recommendation from there. And what we see is that the provision of pharmaceutical-grade opioids as safer supply alternatives in the toxic unregulated drug supply is characterized by a variety of diverse models implemented in practice. The generic term safer supply may generate some conceptual ambiguity. And maybe we don't serve ourselves in just putting everything under safer supply when it comes to trying to generate the evidence that we need for them to be sustainable, effective, efficient, to choose the best models. Results from our concept analysis support, therefore, a breakdown of this safer supply concept into key component or domains to facilitate generation of evidence with well-defined approach. And we can discuss that further. I'll be happy to explain. Maybe in a kind of a ways of trying to link what I just said with the guideline. When we're looking at our guidelines, first line treatment, buprenorphine, methadone, second line, SRAM, third line or other line, and it's not in the guideline, but it's in the slide, injectable OAT for specific populations, studies, long-term outcome, very strong. Into this treatment intensity from low to high intensity that varies with the trajectory of the people, of the person over time. So where do we put this alternative OAT or OAT with combined prescription? Then we probably have to think of it as what intervention, for who, how, and what are the best indicators of success of what we want to measure. One question we have is retention, which is a very good marker in methadone and buprenorphine. Is retention has the same value as count as an outcome other than, mortality, overdose, etc. So we have to think it through and to really select the intervention we want to test, the population we want to test in, and also the type of outcomes that we want. So for future directions, we need to agree on what we do and what we want to measure, identify what we want to generate, what type of data we would like people to collect, easy data, key indicators that would give some ground for impact, and then generate recommendations as soon as possible as we can. And I think we can, because there's many, many researchers and clinicians out there who have the same questions I think we have. And just to go back to all the questions we have about guidelines and all this, a bit frustrating. This is from the Australian Living Evidence Collaboration, and this is what we want to move into within Crism. The line that you see, the kind of green line, you do a guideline, we suffer for 2 years, we launch the guideline. Well, why didn't you do this or that? And then you wait for about 4 years and you do another guidelines and people say the same thing. The living guidelines is something different. And this is something that I think will be very useful in our community, which is for questions around safer supply or other things, is that you have a question, specific question. Take-home medication is a good example, for instance, or and then you look at the literature, it's evolving rapidly. You have specific committee and you relook at the literature on a regular basis and you do recommendations that are also transparent, saying this recommendation has this level of evidence because it's this and that, but it evolves rapidly and we can move the field forward. And for us, it's as researchers, as a network who wants to really move the field and have better treatment. We also want these treatment not to be easy to attack for ideology, and we don't have the data that support the ideology that would be reverse of what we want to do. Thank you. Questions and comments? Yes? Yes, sorry. It's, we have the spot, you know. Yes. This is a completely different question, I think. And I guess my answer would be that this approach, not the event analysis, et cetera, but not the concept analysis, but this approach of living guidance and make sure the evidence that we have, we know exactly what we have, and we built the evidence we need quickly to make sure that if it goes on, if the wind is against the implementation of these things. But I have to, in this particular case, we know that we have evidence that, and we have the Supreme Court, and we have a lot of things in Canada, and they're still attacked for reasons that are absolutely not scientific. So I think we need also political, we need to discuss that at another level than the scientific, but also use the science to try to support them. Oui.
So on the issue of safer supply, I think that what we're seeing in the real world right now is a lot of back and forth.
Mm-hmm.
So as an example, some people who were strong supporters of safer supply and had large numbers of patients have almost overnight do a bunch of urine drug screens. They're negative for hydromorphone, which is a prescribed safer supply, and they're just overnight stopping everybody by the hundreds. And it creates
Okay. No, but I understand exactly what you're saying, and it's maybe what we're trying to say is we want to go, there is a polarized situation right now, and there is very good, I mean, there is a good indication that prescribing short-acting opioids and changing our way of looking at how we care for patients can be very helpful. There are also a lot of concerns on the other side. But then this thing is very, very vulnerable to pulling the plug on one side or another if we don't collectively, and this is what we're trying to think of, collectively trying to find a neutral, not neutral, but middle ground where we bring people together around some specific question priorities of what we want to test, but also what we want to gather with our indicators in the community, which people can do, but they may have the data already, and then come up to build a science at the same time that we're building the recommendations, acknowledging that the recommendation number one, maybe first 6 months, will be relatively weak, but will be on a consensus. And when I'm saying, you know, not talking safer supply is maybe talking about prescribing short-acting OAT, short-acting opioid with OAT in specific, and this is something, something else could be fentanyl patch instead of SROM. I'm just giving examples. But if we begin by taking little pieces and get together and trying to get indicators and building the science that way, instead of having qualitative, I'm not saying it's okay, but qualitative, ecological, etc., but that are looking at an outcome that is very fuzzy, that is called safer supply, and that is this and that, we might get to a place where we have some tools if the wind is, you know, contrary to what we think is good for the patients. Yes? But these were examples. And then what I mainly said is that we have to come to some consensus of the things that we think we really have to document if we want our field to have better treatment for people. And if we are able to do that exercise in the middle of the controversy as clinician, researchers, people with lived experience, and we're able to move the field forward by generating, as I said, as soon as possible, the research that will give as soon as possible recommendations, then we may be in better position in a year or so, or 2 years, to not being stuck with just a controversy. David. No, and I have problems hearing as well, so it's good.
I think if you go back 1 or 2 slides,
yeah,
you'll be on the only slide that mentions supervised injectable opiate agonist treatment.
which one?
Right there.
Yes.
The third line option that you have here is a
I said it.
well-designed randomized clinical trials, including in Canada, but has not been scaled up and made widely available across the country. I suggest that that's an intervention our community could widely and strongly on an evidence-based advocate for, which would eliminate much of the pressure for other models of alternative provision. And the absence of that in a clear national guideline document that the last presentation presented, unfortunately, misses the chance to say to the federal and provincial governments across the country, this is something we badly need that would address many of the concerns with some of the other less evidence-based models.
Yeah, and I get what you're saying. I'm not saying maybe in another world where we would have like twice the budget and twice we could have taken on updating the other guideline that was doing by Crism at the same time as our guideline. But it was another team, another guideline, more recent. We basically thought that updating this guideline would also provide an important piece of information as a foundation to do all the rest of the job that we all know that we need to do. And the second thing I want to say is, I know that I'm speaking here, and I think this guideline is also the guideline that should be the most useful to work with the Canadian Association of Family Practitioners, and to get at least the first-line treatment for anybody that has an opioid use disorder at the beginning. The screening and the first treatment should be available at the first healthcare professional they see. And this is probably what we want to use this guideline for. This is, obviously, these other conversations are ongoing, and I understand that. But today, probably if someone has an opioid use disorder and they walk in, their GP, chances are the GP will say, oh, I don't do this, I'll send you to this tertiary place. And this guideline, I understand for most of you, you don't learn anything. But also realize that this guideline says that we should offer, SROM should be offered everywhere. It does that. The second thing it says that psychosocial is not should never be mandatory, and we should be able to offer OA. OAT is effective without psychosocial treatment. And you know what it means for, transformation of our system in some ways. And it doesn't mean that, and I'm not saying never, that psychosocial treatment is not useful, and it's useful on an individual base. But a lot of places in this country ask people to wait for their psychosocial assessment before even seeing the doctor to get the prescription. So we're not doing everything, but this is, I think, pieces that I hope you're going to convey to your trainees, to your medical students, to your primary care physician partners, that they can do it. And it's something that if we enlarge the global access to people at an earlier stage of their addiction, I think we can do something, not necessarily for, solving the opioid crisis, but this opioid crisis is not an acute crisis anymore. It's something that we've been in for almost 10 years, and we have to use all the tools that we have. This tool is something, I would say, probably more intended to try to move the basis, the stigma at the beginning of our primary care system. Yes. I'm sorry, you have to speak louder. I, yeah, I, so I guess I'll thank you very much for this session. That's the beginning of a conversation, and I hope this guideline at least will be useful and will do its job.